Good morning, everybody. My name is Dr. Robert Tello, and it's my privilege to be the medical director of Loveland Good Samaritan Village here in Loveland, Colorado. And today's topic is going to be the COVID virus. It's the topic that everyone is talking about, we're hearing on the news, and we thought it would be appropriate for me to try to summarize what this endemic, which is going around the world, is all about, and how Good Samaritan Loveland Village is addressing the issues associated with the COVID virus. So we're going to go to a PowerPoint presentation that I've put together, and hopefully by the end of this presentation, you'll all have a better understanding of what is going on with regard to the COVID virus. So the first slide is the influenza virus, and what we're going to do is differentiate the influenza virus from the COVID virus. Initially, everyone thought that the COVID virus represented another form of the flu. Technically, when we refer to the influenza virus, that is the cause of the flu. But there are many viruses that can cause flu-like symptoms, and we're all familiar with these symptoms. They include fever, chills, sweats, cough, sore throat, runny nose, body aches and pains, headaches, fatigue, and on occasion, someone might have nausea, vomiting, diarrhea. But these are all flu symptoms. But there are hundreds of different viruses that can cause the flu symptoms. But it's the influenza virus that technically is the flu virus. So there are three types of influenza virus: type A, type B, and type C. Usually type A influenza virus is the more serious of the three types of viruses. And this is the one that can cause elderly especially to end up in the hospital, and on rare occasions can cause death. The vaccinations that we all get in the fall is against what's called the H1N1 virus and the H3N2 virus and the B Victoria virus. This is the high-dose trivalent, which works better for elderly folks over age 65 because it has a higher dose of the proteins that are in the virus. The quadrivalent vaccine also works against the H1N1 virus, the H3N2 virus, the B Victoria virus, and the B Yamagata virus. All of these are, again, the influenza virus. And what they do is they take some proteins from the wall of the virus, the influenza virus, hemagglutinin proteins, which is the H, and neuraminidase protein, which is the N. And that's where the H1N1 comes from, is they're removing certain proteins, the hemagglutinin and the neuraminidase proteins, from the wall of the virus, put it into the vaccine, and then your body reacts to these proteins to form antibodies against the influenza virus. The influenza virus itself is not in the vaccine, and that's why you cannot get influenza from the vaccine, because the virus is not there. It's these proteins that have been removed from the wall of a dead virus. That is what is in the vaccination. So that's a summary then of the influenza virus. Now the COVID-19 virus is totally different. It is a member of a group of viruses called the coronavirus. COVID stands for Coronavirus Disease 2019. So we call it the COVID-19 virus, but that's truly not officially the name of the virus, but it's a shortened version of the official name. So COVID virus disease 2019 is what COVID-19 stands for. So let's go back to the 1960s. That's when we first discovered the coronaviruses. And there were several strains of the coronaviruses, as you see listed here. I remember studying the coronaviruses when I was in medical school. So as a group of viruses, it is not new. What is new are these newer strains of the coronaviruses. So the MERS virus that you probably have heard of is a coronavirus that caused very serious respiratory disease in the Middle East. So it was named the Middle East Respiratory Syndrome virus. It's a member of the coronavirus group. And it was quite serious, caused many deaths throughout the Middle East, especially in the area of the Red Sea and the Persian Gulf. In 2003, we first discovered what's called the SARS virus, which stands for serious or severe acute respiratory syndrome. So the SARS virus is another strain of coronavirus. It was discovered in China in 2003, caused serious respiratory problems and deaths at that time. Now we come to the COVID-19 virus. The name of that virus is the SARS-CoV-2 virus. That is the actual name of the virus. And we have shortened that to call it the COVID-19 virus. This is what developed in China in late 2019, caused an epidemic there, and of course since then has spread throughout the world, and we now call it a worldwide endemic. So, as I've already alluded to, SARS stands for Severe Acute Respiratory Syndrome caused by the coronavirus 2. How do we diagnose it? You've all heard of the nasopharyngeal swab, where you stick the swab up the nose as far back as you can get it, and you twist it around a few times to get some of the mucus from inside the nose, and then we put that into a transport media. It is sent to a lab that can do the polymerase chain reaction, or PCR, test looking specifically for the SARS-CoV-2 virus. That is how we diagnose an active case of COVID-19. Now, you've heard about the blood antibodies. So within a few days of being exposed to the SARS virus, your body will develop what we call IgM antibodies. That's the way the body has of fighting off a virus. It will form IgM antibodies, usually within a few days or within a couple of weeks. Later, perhaps 4 to 6 to 8 weeks later, the body will form IgG antibodies. And it's the IgG antibodies that we hope will give us long-term protection against a reinfection of the COVID-19 virus. So the body's initial response is with the IgM antibody to fight off the infection, followed by development of the IgG antibody to provide long-term protection against the COVID virus. So what happens if we get exposed to the COVID virus? Based on present knowledge and statistics coming out over the last several months, roughly about 80 to 85% of persons exposed to the virus will have no symptoms whatsoever, or they'll have very minor symptoms, and they think perhaps they have a cold, or perhaps they think they might be coming down with a minor case of the flu. But 80 to 85% will have no symptoms or very minor symptoms. The reason this is a problem is because a person can have the virus in their system and be spreading it to others, but they don't know they have the virus because they have no symptoms, or they might think they have a minor case of the cold. Unfortunately, about 15 to 20% of people who get exposed to the virus will develop severe or very critical life-threatening illness. And these are the ones that end up in the hospital and unfortunately can end up on the ventilator. And then, of course, there is a mortality rate, and right now the figure seems to be fairly stable, that about 5% of those individuals who test positive for the virus have a mortality rate of 5%. So that's kind of the general course of the disease. So what are the risk factors for developing these serious and critical symptoms due to the COVID-19 virus? The greatest risk factor for becoming seriously ill is age over 75. Second risk factor, age 65 to 74. And then we get to the risk factors related to multiple underlying diseases: lung problems, heart disease, kidney disease, cancer, diabetes, if you're immunocompromised, or if you are obese. These are risk factors for developing serious illness from the virus. Comment on heart disease. We're finding out that this COVID-19 virus has a predilection to do serious damage to the heart. And if you already have a heart condition and you get infected by the COVID virus, there's a high risk that you will get seriously ill with heart failure and serious heart damage, which is one of the causes of mortality with this particular virus. Of course, if you have underlying lung disease such as COPD or asthma or other types of lung diseases, that also puts you at very high risk for getting seriously ill from this virus. I want to make a comment on two other risk factors. The way that this virus gets into lung tissue is by way of what we call ACE receptors. It stands for angiotensin converting enzyme receptors that we all have in our lung tissue. And this virus goes directly to those receptors that we all have, and that is how it enters into our lung cells to cause lung damage. A recent study was published that shows that in asymptomatic individuals who have the COVID virus, 50% of them had abnormal CAT scans of their lungs, even though they were asymptomatic. So this virus enters into our body by way of the nose and the mouth and goes directly to the lungs and gets into the lung tissue by way of these ACE receptors. It's also been shown that different people have different numbers of ACE receptors. So if you have a very high number of ACE receptors in your lungs, it puts you at even higher risk for getting seriously ill from this virus, as opposed to if you're lucky enough to have a low number of ACE receptors in your lungs, it decreases your risk of having serious respiratory symptoms from the virus. We have no way of accurately measuring from person to person how many receptors you have. So it's just luck of the draw, probably under genetic control, how many ACE receptors you have in your lung tissue. And then the final risk factor is how much of the virus did you get exposed to? So we call this the virus load. So this particular slide here shows that if someone coughs directly into your face at a close distance and neither one of you have a mask on, that gives you a huge virus load exposure from the person who has the virus to you who does not have the virus. But because of this high virus load exposure, you are very likely to get ill and perhaps seriously ill. On the other hand, if the person who has the virus coughs directly into your face and you have a mask on, you're still at high risk, but a little bit less risk. If the person who has the virus has a mask on and you don't, then you are at medium risk in terms of a virus load exposure. If both of you have a mask on, the person with the virus and yourself, that lowers the risk even more in terms of getting ill. And if you're 6 feet apart, then you have a very low risk if you both have a mask on. So this emphasizes the importance of the mask in terms of the amount of virus that you might get exposed to by somebody who has the virus. And of course, if you're safely in your house and somebody is outside coughing with the virus, then of course you have no risk. You are adequately protected. So to prevent the illness, social distancing of 6 feet and staying in your home is very, very important and probably the most effective way at preventing yourself from getting exposed to the virus. Masks, as we have just pointed out, very, very important. The reason we wear a mask is to help prevent you from spreading it to others. You may have the virus and not know it, but if you're wearing a mask, you decrease significantly your ability to spread that virus to someone else. Cleaning, of course, is extremely important. You've heard about hand washing. Soap and water work extremely well. The high alcohol hand sterilizers work very well. If you're cleaning hard objects to get rid of the virus, these are the bleach products and disinfectants. They all work very, very well. We know from studies that this virus stays alive on hard surfaces, whether it be paper, a desk, a table, handles. The virus will stay alive for up to a few days, likely several hours minimum. So that's why washing of hard surfaces is very important. In my particular household, when we go to get the mail, we have gloves on. We take the mail into the garage. We'll open up the envelopes or the boxes in the garage, throw the envelopes and the boxes into the recycle bin, and then take important mail into the house. But be aware that touching surfaces that might have the virus on it is important to protect yourself from. Those of us who take care of COVID patients, it's important that we wear personal protective equipment, the masks, the shields, the gowns, to protect us from getting exposed to the virus. The vaccine is going to be the game changer, but the vaccine is probably 1 to 2 years away. A lot of countries are doing research in this area, and they will take proteins from the surface of the COVID virus and make a vaccine out of it to trigger the bodies to produce antibodies against this virus, just like it does against the influenza virus. So when it comes to masks, they're important, of course. The N95 respirator mask is the most effective way to keep the virus out of your system. Surgical masks are what most of us caregivers wear, nurses, CNAs, doctors, who are not in direct contact with a sick COVID patient. And then comfort masks are important to help you from spreading the virus to others. These are the cloth homemade masks. This particular mask probably won't work. Sorry about that. The surgical mask on the left and the N95 mask on the right are the masks that caregivers will be wearing, and these are the best masks. So how do we treat a case of COVID-19 if they are sick and they end up in a facility, whether it be a nursing home or a hospital? The first thing, of course, is to isolate them. If they have fever, aches and pains, acetaminophen, also known as Tylenol, is what we use. For lung damage and respiratory problems, we give them oxygen. We give them medications to try to improve lung function. And of course, as a worst case scenario, they may end up on a ventilator. As I've already mentioned, this virus attacks the heart, and we do give heart medications to try to preserve and improve heart function. We have found out that one of the unique qualities of this virus is that it causes blood clots. It thickens up the blood, and these individuals are having strokes. They're having pulmonary emboli in their lungs and in their legs. So it's very common now that we will put these individuals on blood thinners, and when they are discharged from the hospital, they will usually be on some sort of a blood thinner. Remdesivir is the drug that holds the most promise for treating the virus, killing the virus, and shortening the length of illness due to this virus. So there's a lot of research going on right now with remdesivir. Other drugs are being investigated, but the remdesivir has the most promise as of today. A lot of talk about giving antibodies. So if you do recover from COVID virus, as I've already mentioned, your body has formed IgM and IgG antibodies. So there's research taking place right now about giving convalescent plasma that contains antibodies against the virus and giving it to those acutely ill, very sick, hospitalized patients in the hopes that these antibodies will help to kill the virus and decrease the illness of the virus. So this is new research going on as we speak. The general recommendation is before you give plasma that contains these antibodies, you have to wait for about 28 days without having any symptoms. So if you go for 28 days with no symptoms, you've made a full recovery from your COVID infection, you are then eligible to give your plasma, which hopefully contains high levels of antibodies. Now, different persons have different abilities to form antibodies. So the older we are, the less capable our body has of forming antibodies. The younger you are, generally speaking, the more capable you are of forming high levels of antibodies. So just because you've had the infection doesn't mean you have a high level of antibodies. So the titer of antibodies can vary from person to person. So I'd like to end this talk by talking a little bit about what are we doing here at Good Samaritan Village in Loveland with regard to COVID. We have a COVID leadership team at our facility. Lisa Melby, who is our Chief Executive Officer. Julie Marco is our long-term care nursing home administrator. Brittany is our infection control nurse. Marcia Lynch is our director of nursing. And I, as the medical director, we form the COVID leadership team. So what are we doing? First of all, we put together our set of priorities. The priorities are the health of the residents, health of the employees, and then provide education and communication to the families and to the residents and to the employees about the COVID virus and what we are doing. We were the first facility in northern Colorado to shut our doors to visitors, but we have set up communication ability using iPads whereby families can communicate with their loved ones in the long-term care facility or the assisted living facility. Window communication, that is through the windows, is another good and easy way of communication. Zoom is an excellent tool for communicating by way of computers. So there are communication technologies available to provide communication with the residents in our facility. So we've talked about visitors. At first, when we closed our doors to visitors, it was hard for families to perhaps understand why we did that. And we got a lot of kickback from some family members and from friends as to why we were not allowing them into our facility. But thank goodness everyone caught on to why it was important. And we're happy to report that we are COVID-free, in large part because we have kept visitors out. When we order labs on our residents, the nurses now draw the blood and the tubes are brought to the front door where a professional lab will pick up the tubes of blood and take them to their labs. But the transporter individual is not allowed into our facility. The nurses will draw the blood. So we try to keep everyone out of our facility as much as possible. We screen everybody who we admit into the facility, especially the employees. We're taking temperatures of everyone. They have to answer a questionnaire with regard to, are they having any symptoms? Have they done any travel? Have they been exposed to anyone with COVID? And so we screen everybody every day before we let them into the facility. We used to have group activities. We no longer have group activities. Everyone is kept in their room as much as possible. We'll play doorside bingo, for instance, and call out the numbers, but everybody is in their doorways or in their rooms. And we use loudspeakers so they can hear the numbers that are being called out for bingo, as one example. There are several volunteers that provide entertainment, singing. These are mostly staff members who have the gift of providing music with guitars, piano, and singing. Testing. We have the ability to test anyone who might be having symptoms, and we have tested right now about 10 residents in our nursing home who had a cough or a low-grade fever, and I'm happy to report that everyone we have tested with any suspicious symptoms, they have all tested negative for the COVID virus. Employees, if they develop any symptoms, they are told to stay home and contact their primary care physician. There's a new recommendation by the federal government that just came out that all residents of a nursing home and employees be tested for the COVID virus. The biggest problem, of course, is access to testing abilities. So we have increased our supply of COVID testing swabs, but we don't have nearly enough yet to test everyone. But we're working on that. New admissions from the hospital or from any other outside facility, they must have a COVID negative test before we will admit them. Hospitals at first gave us some kickback on that. They didn't want us to do that, but now they do understand. And So we are requiring that before we will take any new admissions, that they have a COVID negative test on file. In addition to that, after they arrive at our facility, we repeat their COVID test and we put them in isolation for anywhere from 1 to 2 weeks, waiting for the COVID test to return, which would be their second test. Supplies, we have increased our volume of supplies, the personal protective equipment that we use, the gowns, the masks, the shields, the gloves. We have a huge supply of equipment now. And transfers to the hospital, emergency room transfers, we're trying to keep that to an absolute minimum. We have increased our supplies of oxygen delivery equipment, our IV equipment. We can now provide intravenous treatment for patients that are dehydrated or have a low blood pressure. So we have prepared ourselves to treat patients in-house as long as they are not in a life-threatening condition. Recently, within the last couple of weeks, we have had 2 infection control surveys done at our facility. The state has wrapped up its ability to do surveys of nursing homes because there have been so many cases of COVID viruses in nursing homes and so many deaths in the geriatric population of nursing homes. So just in the last 2 to 3 weeks, we've had 2 state surveys come into our facility, and both surveys gave us a 100% perfect rating for our infection control policies that we have set up in our facility. So we're quite proud of that. So as of today, there are no COVID cases in our long-term care facility or in our assisted living facility. And I thank all of you who are watching this presentation for your cooperation in abiding by all the policies and procedures that we have set up here. The employees that we have, the COVID team that put together our policies, the families, the residents, everyone has been very cooperative, and we highly appreciate that. It is because of all of you that we are COVID negative in our facility. Thank you very much.